In this presentation, I'll be talking about atrial septal defects. I'm not going to review the whole process of fetal circulation because that's just a lot to go over in 5 to 10 minutes, and we really don't need to know all of that to talk about atrial septal defects. What we do need to know is that a healthy infant has a foramen ovale, so that is the opening between the two atrias. And after they're born, that naturally closes a few weeks to months after birth. So infants with an atrial septal defect, that doesn't happen. So it's a congenital abnormality. And something that I thought was kind of interesting was that the CDC estimates that about 1 in every 1,800 babies born in the US have an atrial septal defect. So that number isn't really exact because sometimes they go undiagnosed. So that data is a little bit skewed, but we'll talk about that here in a little bit and why they sometimes go undiagnosed. Just to keep things simple, and because this is a pediatric presentation, I'm going to refer to the patients that have ASD as children and infants because that's the population that is most commonly affected. Now, that's not to say that adults don't have atrial septal defects. That just means that, most of the time we see it and treat it when they're children. So what it means to have an atrial septal defect is that there's an increased blood flow through the lungs. There's also a mixing of oxygenated and unoxygenated blood, which can lead to, an overworked right side of the heart and pulmonary hypertension. The 4 types of defects are secundum, primum, sinus venosus, and coronary sinus. In the secundum, the middle part of the septum is the place with the defect. So that's the most common because that is where the foramen ovale is located on a normal, healthy fetus. The primum, the defect is in the lower part of the septum, and that's sometimes seen with other defects. The sinus venosus, it is in the upper part of the septum. If a child has this, the sinus venosus, they probably have some other congenital heart defects. And the coronary sinus defect is the rarest and it's the most serious. There's actually a hole between the coronary sinus and the left atrium. Like the whole wall septum between it is completely missing. And that is the most rare, and it will definitely require surgery to repair. We're not really sure what exactly causes the foramen ovale to not close in the couple of weeks to months after birth, causing an atrial septal defect. We do know that moms who get rubella during the first trimester of their pregnancy have a higher chance of having a baby with an atrial septal defect, along with mothers who are diabetic or have lupus. Mothers who use drugs and alcohol during pregnancy, we know can cause a whole slew of other issues and damage to their fetus. Family history and genetics, there is a link, but for the most part, it's kind of unexplained why it happens. There's a couple of things that can be done to find an atrial septal defect. A lot of times they're found accidentally during well baby visits. They can hear murmurs and the doctor can suspect that they have a defect and, request an echo or an EKG. If the infant has more congenital abnormalities that might warrant further testing, the doctor may want to do a cardiac cath or an MRI. So with the cardiac cath, they can actually go in and visualize or potentially fix the structures that have the defect. So that would be the wall between the atria in this case. So back to the beginning when I said that sometimes they go undiagnosed. The reason why is because sometimes atrial septal defects are actually asymptomatic. So maybe at some point, whenever this child is a teenager or adult, they may go to the hospital for something else and, get some testing and stuff ran and then find out, oh, you have an atrial septal defect. a small opening, it's been asymptomatic, it hasn't bothered them for years, so they're just going to monitor it and not fix it unless there's other complications and issues. Now, for children that do have issues, they can have shortness of breath, fatigue, they can have arrhythmias, murmurs, and even potentially a stroke. So the fatigue will happen after feedings. They might be crying for extended amounts of time, causing them to just be exhausted. And like with the murmurs and arrhythmias, a doctor will hear those hopefully at a well baby visit, and the arrhythmias will obviously be seen on an ECG. The stroke is very severe, and if a child is at risk for having a stroke, odds are it's not from an atrial septal defect, it's from some other things going on, and the atrial septal defect is just kind of a contributing factor. So, some things that may alert parents to an issue are that the kid is just so tired after feeding or bath time that they're just sleeping way more than their other children did. Maybe they notice them struggling to breathe, or, after feedings, just not being able to get enough breath. I keep saying feedings, but whenever they're a newborn, I mean, what do? They cry and they eat and they sleep and they poop. So those things are what we're going to notice are abnormal because that's all they do. So we just need to also be sure to ask parents these things because maybe they haven't noticed it. And it's like, well, now that you mention it, yeah, they do sleep a lot more than my other kids did, or yeah, they are kind of gasping for air after feedings, and there's just something not right. There's a couple of different therapy options we can do for kids with an atrial septal defect, depending on how severe and what type of defect they have. Some common ones are beta blockers and anticoagulants. Beta blockers, obviously, to slow down the heart rate, and anticoagulants to prevent a blood clot that could potentially become a PE. Um, like we talked about in the diagnostic portion of it, we can do a cardiac catheterization to repair the defect, or we can do an open heart surgery. Now, the coronary sinus defect and the sinus venosus defect, the only way to repair those is through an open heart surgery, which is scary to think about, but from my research and reading, it seems that an open heart surgery to repair just an atrial septal defect is relatively minor in the grand scheme of things. Not to say that that's not still stressful and still surgery that an infant has to go through. But the main thing that we do for atrial septal defects is to monitor them. They'll require lifelong monitoring, and maybe later in life they will get some form of treatment like medications. Some complications that can occur if a large atrial septal defect goes untreated are right-sided heart failure, arrhythmias. They can have an increased risk of stroke, which in turn shortens their lifespan. Some other less common symptoms, but they're more serious, are pulmonary hypertension, which we know is increased blood flow through your lungs that increase the blood pressure in your lungs arteries, and Eisenmenger syndrome. I don't know if I said that right, so I'm not going to say it again, but that syndrome is caused by years and years of pulmonary hypertension, and it causes permanent lung damage. It is not common in kids or people, I should say adults, that have just an atrial septal defect. As I said before, the atrial septal defect that causes stroke and the syndrome, more than likely there's some other congenital abnormalities going on with it, and the atrial septal defect is just there with it, unless it's one of the large ones. Some nursing diagnoses to go along with an atrial septal defect include decreased cardiac output related to a structural abnormality, aka the defect, and we know that they have the defect because they have murmurs or they're short of breath, for example. Another one is activity intolerance. I talked about that a little bit during the slide about what parents may notice that will alert them that their child has an issue. It's related to oxygen insufficiency because their blood is mixing. They're not getting oxygenated blood to the whole of their body. So they'll be tired after what we would think of mundane activities, eating, going to the bathroom, and sleeping, because that's all babies do. Another thing that is a nursing diagnosis, maybe not exactly for the child, but for the family, is ineffective family coping. When you're dealing with pediatrics, you have to take into the whole picture, which of course includes the parents. I mean, that's their kid, they're involved. So that can be very stressful to hear that your child has a heart defect. How small or large it may be, all parents hear is heart defect equals death. So they can be having a situational crisis. They might lash out in anger. They could be scared, and I'm sure they'll be anxious through the whole treatment. No matter how small or large the defect is, we have to intervene. So one of the most obvious things that we can do is a focused cardiac assessment. We need to look them up and down, head to toe. Notice their color, their temperature, their pulses. How are they breathing? How are they eating? Are they pale? Are they cyanotic? Is their abdomen swollen? Is there anything going on in their assessment that could alert us to a potential cardiovascular issue? To promote rest, we can group activities and care together. That may be difficult with a toddler, but we can try. We need to also educate the parents. We need to keep them informed and let them know what we're doing to their child and how we're going to help them and how they can also participate in care. We need to make sure that we schedule follow-up appointments. Um, Even if we're not going to do surgical treatment or medications, the child still needs to be followed up on because no matter how big or small, it's still a congenital defect to their heart. Um, as I said in the last slide, we really need to support the parents emotionally for sure, because this is an anxious time for them. They may not know exactly what all of this medical terminology means, so we need to make sure that we're doing our part to help them understand what's going on with their child. And if we're not going to do any medications or surgeries, we need to just monitor them for their whole entire life. Even if we do medication or surgeries, they're always going to have a history of an atrial septal defect, and that needs to be noted. And this is just my resource page, so that's the end of my presentation.